Okay, so the joints by functional classification, structural classification, and then a lot of this chapter is naming joints and looking at characteristics of joints. So sometimes you'll hear it's a fibrous joint, and you'll reference that as being synarthrotic or immovable. So this right here all goes together, then this line goes together, and that line goes together, as far as classification and organization are concerned. Towards the, after we're finished, I'll bring this back up again so that we can go ahead and get going here. Okay, so where are we going to find a joint? Anywhere two bones articulate. And what does articulate mean? To touch. Outstanding. So we can classify those joints in two ways, functional and structural, which is what I had on that chart there. Okay, which is the whole first part of this chapter. The three functional classifications. This is pronounced synarthroses, this is amphiarthroses, diarthroses. If it has that root, it means the same thing. So you might see synarthrotic, amphiarthrotic, diarthrotic joints. Okay? Synarthrotic means that they're immovable. They don't move at all once they're fully formed. Amphiarthrotic means they're slightly movable, and by slightly, that could mean like it just leads a little bit, or it has a little bit more give. So we'll talk about those characteristics. Diarthrotic is our freely movable joints. So like when you talk about your knee joint, your shoulder joint, your elbow joint, those are all diarthrotic joints. Okay? The three structural classifications. So just right here we did functional classifications. The three structural classifications are fibrous, cartilaginous, and synovial. So if you wrote down that chart, and again I'll show you that at the end, it has those and it organizes them with their corresponding function. So now, fibrous joints. Fibrous joints are a type of structural classification, and that's what this slide is referencing. So fibrous joints are a type of joint, and anytime I hear fibrous, and this is just one of those memorizing things I've come up with, it reminds me of burlap, where there's not a lot of stretch to it, but it's very tough and durable. Like there's not a lot of elasticity. Fibrous joints have no joint cavity and are synarthrotic. That's their functional classification. So that's why I put that on that chart. And synarthrotic again means that it's immovable. There are three types of fibrous joints. One you and I have already covered. Sutures, so like in our skull we have sutures, syndesmoses, and gomphoses. Beginning with sutures. So you and I have already talked about sutures. Sutures are, we have them in our skull, our cranium, specifically the cranial bones, the coronal suture, sagittal, lambdoid, and squamous sutures. They allow for the compression of the skull during birth, and then they ossify as you age. Sutures are also referred to as synostoses when you become older. And I had put that on that chart too. So it may say sutures / synostoses. Anatomy is a whole different language. And that's why these doctors can talk over your head, because they use these terms that mean the same thing. So don't become overwhelmed. Again, I made that chart to help you kind of organize it. So sutures are immovable. Here's a diagram of a suture. And we discussed that previously. Okay, syndesmoses, a type of synarthrotic joint. They are connected by ligaments. They move little to none at all. So it says little to no movement. An example is the distal tibiofibular joint. Where is this? Distal tibiofibular joint. Yeah, it's the ankle. And this is a horrible joint to mess with. But right here, where the fibula and tibia articulate, and this is distal, so it's further from the part. You know what I'm talking about. I'm not in the camera. It's further from the point of attachment. This right here doesn't move very much at all. A lot of times when people slip and fall and they dislocate their ankle, it's this that they dislocate. Okay? And if you tear that ligament there, sorry for your luck, it doesn't fix itself. So you have to go back in and have surgery to get that little fella fixed. Oh my gosh. Good grief. Okay, so tibiofibular joint right there. Okay, gomphoces. Gomphoces are referred to as your periodontal ligaments. Where are these located? In your teeth. Every single one of your teeth is bony in nature, osseous in nature. And then, of course, your maxilla and your mandible are also bones. So bone to bone is ligament. So your periodontal ligament is the ligament that holds your teeth in place. And as long as you have really good oral hygiene, those ligaments will last your entire life and you won't lose your teeth. But if you don't brush your teeth, or if you go for a while or you get an infection and it kind of turns red, like when we're going to talk about gingivitis in 2402, that bacteria is getting in there and they loosen that ligament. And so what does that do to your teeth? If the ligament becomes loose, what happens to your tooth? It falls out. So you start to see that. We can tell and those of you who go further into clinicals and stuff, you can tell the nature of someone's heart by the state of their teeth. If they have good, healthy teeth, then they probably have a pretty strong heart. That means that they've taken care of themselves. If they don't, there's buildup there. You can guarantee if there's buildup there, there's buildup in the heart. And there's quite a few correlational studies that will show that. So that's one of those things where you observe your patient and you try to read into it. But those periodontal ligaments are what holds your teeth in place. So the more oral infections you have, the looser those ligaments become, the more likely you are to lose your teeth. So here you have that ligament right there, and each tooth has it, so holding it there in place. Okay, cartilaginous joints. Cartilaginous joints, they have cartilage, which is why they're called cartilaginous joints. They're not highly movable, so that makes them amphiarthrotic. That's that second classification, slightly movable-ish. Two types of cartilaginous joints, synchondroses and symphyses. Synchondroses and symphyses. Synchondroses, I can't read this. Synchondrotic joints, there's where hyaline cartilage unites them. For example, your epiphyseal plate, where is that? Epiphyseal plates. Your growth plates. Do you see how that's not really a movable joint? It could be if it breaks, but it's not really a movable joint. Okay? The cartilage that articulates the first rib within the nubrium, what's that? Where is that? First rib with the manubrium. Where's the manubrium? It's the very top part of your sternum. Yes, fantastic, fantastic. These are all synarthrotic, meaning that they are immovable, or there should be little to no movement. So epiphyseal, and then here is that cartilage there. Now symphyses. Symphyses are like here, this pubic symphysis, where there's normally not any movement, however there could be movement. Okay, so here's where we get to the amphiarthrotic part. The amphiarthrotic part, where it could allow for a little bit of movement. So we see that here. We also see that here. We don't want movement naturally, but movement could occur. Okay, so amphiarthritic. Synovial joints are the last classification of joints. Synovial joints are diarthrotic, which means they're freely movable. The problem with having synovial joints is because they're freely movable, they tend to not be very strong. So we have to look for ways to reinforce them. And the rest of this chapter, we will be talking about ways to reinforce them. Either to classify them or reinforce them. But let me just tell you overall, it's ligaments and muscle. Ligaments first, and then it's reinforced with muscle. The stronger the muscle, the better the joint. This is a very general joint. This isn't one specific joint. characteristics that you will need to become familiar with, and you'll see as we go through these diagrams today. I have two bones, so I have an articulation there. It's natural to see articular cartilage where two bones would articulate because it reduces that friction. Because this is a movable joint, freely movable joints, an arthrotic joint, we have what we call a synovial cavity. So you have a joint cavity. So I have that articular cartilage, but then I have this membrane here in green that's closing that cavity off. And then I fill this with fluid, synovial fluid. Like many of you who might be athletes or had injuries early on in life, they talked about having fluid on your knee. Like there was fluid, and there would be fluid pockets. Usually, if you damage your knee, the fluid from your synovial membrane, so your synovial fluid, flows out into your knee and makes it kind of swollen. And they can just put a little needle in there and withdraw that fluid, and the swelling goes down immediately. Like it's not swelling because it's damaged, it's swelling because that fluid is getting out. So when they say you've got fluid on your knee, that's what they're referencing. So we have the articular cartilage, we have this synovial membrane, and then synovial fluid inside of it. This all helps to reduce the friction and aid in lubrication so that that joint moves without issue. Okay, that would be the goal for that. Other features that we have in synovial joints, fat pads and articular discs, which you and I call the meniscus or menisci because that's plural. Fat pads are really important. Also bursa, and I'm going to show you what all these are when we look at a diagram. But bursa and tendon sheaths. Let me show you what I'm talking about here. Okay, does anybody have any idea where this joint may be? How do you know? It says scapula. You might see humerus. It kind of looks like the shoulder. But again, trying to navigate yourself and figure out where you are. Here, I have two articulating bones. So, of course, I'm going to have articular cartilage there in blue. The synovial membrane closes, well, it goes underneath that, closes that off. And then this is filled with synovial fluid for lubrication and allowing for the movement and no hitch in that. I don't see any fatty pads here, but I do see bursa. That green with the yellow inside, it's literally a little packet. It's a synovial membrane with fluid inside. Some of you are too young for this, but they used to have these things, these bath balls that were squishy. And they kind of look like Tide Pods now. That's a good reference. I just thought of that. Those little Tide Pods where they have that plastic lining and they have the fluid inside, that's what bursa are. And we stick them in between. We don't. But in our body, they're there, and they help our muscles and tendons that are rubbing against each other a lot, especially in these high frequently used areas. And they kind of roll back and forth so the muscle and tendon is not rubbing against each other. That's what this bursa is doing there. That's what this tendon sheath is. This tendon sheath is just a big insulating factor for that. It keeps it from wearing away. When your joints are nice and healthy, all of this is intact and you feel no pain. If you have bursitis, you have an inflammation of those bursa. So you're overusing that joint, and it causes pain. We ice it and rest it. Here's a bursa up close, and it's kind of showing you how it has the ability to roll around as those well, that right there is a tendon. It's going to move across, and it reduces that friction and allows for that nice, easy movement, and there's no rubbing on tissue to tissue. What stabilizes a joint? If you have a freely movable joint, what factors stabilize it? Muscle, ligaments, and tendons, okay? And then we also have a little bit of cartilage there as well that I didn't mention earlier. But yes, ligaments, it's going to be ligaments, cartilage there, ligaments holding it together, and then muscles that reinforce it. Every strong joint will have that. It mentions here that muscle tone will keep your joints nice and healthy. You don't want your muscles to be flabby. Because if they're flabby, there's no reinforcement on that joint. And like people who tend to be really, really heavy, and a lot of patients that you'll do lift assists on can't support themselves because their muscles aren't strong enough to support the weight they have. So when they do put weight on it, no exaggeration, the bones slide past each other. So like the tibia will slide away from the femur and they'll just fall. And they didn't break anything. They just can't support their own weight. There's not enough muscle there. So that you will see that especially in your geriatric older patients or people who let their weight get out of control and they can't support their own, but they can't stand up, they can't support their own body weight. This next chart labels every joint in your body. Okay? It tells you the name of the joint, it tells you what bones articulate, it tells you what structure type it is. So the structural classification, and here's the functional classification. Okay? The ones I would study are the ones that were on my review, and if there's none on my review, then this is a great reference tool. Okay? I don't know what's on your review. So, not right this second off the top of my head. Alright, but here's all the joints in your body. The term origin versus insertion. This is a preface of what we're going to get into the next time we lecture. And hey, just so you know, next time we don't lecture, I'm so excited. We come in, we take a test, and we just go to lab. So we work labs the next time. And I should have said that at the beginning to remind you because we lost a few students, but just keep that in mind. That next week we don't lecture on Tuesday. We will on Thursday, just not on Tuesday. Okay? And whatever I was about to say. Origin and insertion. Origin is where a tendon or muscle is attached to the immovable bone. Insertion is where it's attached to the movable bone. Let me tell you what that means. For example, my bicep. When I flex my bicep, does it move my humerus? It moves my forearm. So it inserts there. So its origination point, where it attaches to the immovable bone, it's attached to my humerus. Its insertion is what bone it attaches to that I move. So when I flex that muscle, it moves those bones. So the origination point is its immovable attachment, and the insertion point is the movable attachment. So for my biceps, the origin point is the humerus, the insertion point would be my ulna and radius. That's a preface to what we're going to get into the next time that we lecture. Synovial joints have range of motion. Some of them move a whole lot, some of them don't move as much. We have non-axial, uniaxial, biaxial, and multiaxial. What do you think the difference between these is? Non-axial, uniaxial, bi, and multiaxial. Yeah, and the range of motion on which axis that it moves. Does it just go in one plane? Can it go in all planes? And so on. 3 movements are allowed by these different joints, the non-axial, uniaxial, bi, and multiaxial. Gliding, angular, and rotation. When we talk about angular movements, that's like flexion and extension, and we have a lady in here doing all the demonstrations for you. Normally we would get up and do this together because it would be like a 2.5-day, 3-day lecture. We're not going to do that. We're just going to keep going. But a gliding movement is where the bones will glide past one another. Okay? And so in my carpals, they do that. Oops. I'm going to show you pictures too. But gliding occurs in the intercarpal and intertarsal discs, as well as the articular the processes of the vertebral column. The articular processes of the vertebral column. Okay, so gliding, not any type of hinged movement. Angular movement, flexion, extension, and hyperextension. Flexion means the angle gets smaller. Extension means the angle gets bigger. Hyperextension means you move it beyond its normal range. The lady here, when she does flexion and extension, hyperextension, she does flexion, so she made it smaller. Extension, she made an angle bigger, and she goes hyperextension. Okay? So, flexion, extension, hyperextension. Abduction versus adduction. I am a memorizer. You probably already got that from me. Abduct means it gets taken away. So, abduction means away from the midline. So, abduct, adduct. Ab, add. Adduction means it comes towards the midline. So, ab, add. Abduction, adduction. Abduct, abduct. Adduct. Okay, so abduct, it means it goes away. Circumduction, I'm making a cone, but I'm not twisting. So I'm just going like, but there's no twisting, like I'm not like twisting, just circumduction. Rotation is what I have here, where you go medial, lateral. Medial, lateral. And we're going to end up calling that supination, pronation. Supination, pronation. It mentions here that you also do this during the C1 and C2. Where are those? Right up here. So rotation. And we talked about that earlier. Here is gliding. Here you have flexion, extension, hyperextension. Again, flexion, extension, hyper. She's a nice looking lady. Okay, same thing. Woo. All right, abduct, adduct. Abduct, adduct, circumduct. Rotation, rotation. Okay. I'm here for your entertainment purposes, 1 to 5 every Tuesday and Thursday. Supination versus pronation. Supine, we talked about this term in chapter 1. So you're up, so supine, we're just talking about the hand here. So supination, pronation. Supination, pronation. And that's just a movement of a joint that's allowed in that. If you say the patient was prone, that means that they were belly down. Okay? That's not pronation. Dorsiflexion, plantar flexion. This is you flexing your toes. Dorsa means that you're pointing it up like it's a full flex. Plantar flexion means you're pointing it. So dorsiflexion, plantar flexion. Dorsa. Okay? Good little workout going there. Inversion, eversion. This is your foot. You're moving it towards your midline, away from your midline. Inversion, eversion. Inversion, eversion. You should practice on yourself and your kids. Protraction, retraction. She's going to show you. She does it much better than I do. But she uses her jaw. And she's like, protraction. I can't do it. She does it better than I do. Elevation and depression. Elevate means to lift. Depress means to put down. And she uses your jaw as well. And so elevate your jaw like. And then she said depress your jaw. Okay, so you'll see her. And then opposition. Okay, so supination, pronation, dorsiflexion, plantar flexion, inversion, eversion. See? She does it much better. Elevation, depression, opposition. All right, synovial joints. Plane, hinge, pivot, like plane as in a plane. Condylar, saddle, ball and socket. Here's the reality. You have a set number of joints in our body, but we can classify them in different ways. So once you kind of get to, first of all, if it's not on your review, don't study it. Don't stress yourself out. But once you start to learn this, because if you do go into like orthopedics or something like that, you're going to have to know all of these. You'll have a class that's just on joints. Like you'll have a joint class. Okay? Sorry. But where all the different joints have multiple classifications for the same thing. I like these diagrams. I don't like this, but it's telling you this is what that motion looks like. It's showing you where it is. It gives you the name. It tells you how many axes, and then it tells you where you can find them. So I do like these diagrams because they're good for referencing. You're not trying to pull a lot of things together. Okay. Hinge joint here. It's moving in one axis, showing you kind of what it looks like. Here's an example of where it's located. Here are all those listed out there. Okay, here we have the pivot joint, the radio-ulnar joints. Where is that? Radio-ulnar. Very well. Okay. Atlantoaxial. Good. Metacarpophalangeal. Metacarpal is here. Phalanges are here, so metacarpophalangeal is in between there, yes. Okay. If someone said, I think you fractured your metacarpal, or I think you dislocated your metacarpophalangeal, you'd be like, oh my God. It's not even a big deal, right? I'm telling you, these doctors, this is going to be you one day, and when I walk in and you try to feed me this line of crap, I'm just going to look at you and be like, really? Like, I'm going to pay you. You already know. But, really? Like, can you just say, that's your knuckle? Please. Okay? Anyways, it shows you where we're talking. Again, saddle joint, metacarpal joint, biaxial movement it's showing you. And the saddle joint is here on the thumb. It's a different setting. Like, it's not the same type of setting we have on the others. So, that's what it's showing you there, that saddle joint. Ball and socket, most of you have heard that at some point in your life. Ball and socket joint. Okay? And that's because of the range of motion that allows its multi-axial, shoulder joints and hip joints. Now, the remaining, we are going to divide up just these joints and just talk about them generally. Patterns that you're looking for. You want to look at the synovial membranes. You'll see the synovial fluid because these are fairly movable joints. They're going to be reinforced by ligaments and then by muscle. So you're going to see that pattern in every single one. All right. We'll start with the knee joint. It says femoral patellar joint. Femoral patellar joint. What's that? Yeah, this is where your knee is. Okay, so your femoral patellar joint, that's where your knee sits. Lateral and medial tibiofemoral joints. Lateral and medial tibiofemoral joints. And lateral and medial. Yeah, the inside and outside of that. Okay, here is your knee joint. We have, a lot of times people immediately say ACL, PCL. Okay, your anterior cruciate ligament, your posterior cruciate ligament, they are named based on where they touch the tibia. So the anterior cruciate ligament articulates or touches the anterior portion of the tibia. The posterior cruciate ligament attaches there, posterior. Here on this joint, there's a lot that I can pull from this. I see some adipose here, which is good. It helps with shock absorption. Then I have, of course, tendon here. This is the patellar tendon holding my patella in. I can see bursa, lots of bursa. I can see my synovial membrane, synovial fluid. I can see articular cartilage. All of that reinforcing that joint. This is clearly a very movable joint. There's a lot there to support it. But that's just the baseline. Then we have ligaments, additional ligaments, what we'll end up calling collateral ligaments, and then we'll put muscle on the outside of that. Here is your meniscus. When people talk about your meniscus, or I think I tore my meniscus, they're referencing this structure here. This right here is a really tight fibrocartilage that is there to support the weight and the movement, the repeated movement of that joint between the tibia and the femur. Because remember, the tibia and the femur are the only two that articulate. The fibula does not. When you tear this, there is not anything you can do for it because it is avascular, so it will not heal on its own. But it will stick up and it will cause you pain. And so when it does that, it hurts to walk, so then you don't walk, then that muscle atrophies, then you gain weight, and you get problems. So a lot of times we say, okay, you're going to rest until the swelling goes down, and then we're going to go in and fix that. Okay, and it depends on the extent of the tear. Same thing with the ACL or PCL. If you tear those, and literally the only reason those two bones are held together is because of the ACL and PCL. So if you tear one of those, it's not holding it together anymore. Like it just kind of dangles. Okay? And now you can see there's more ligament reinforcing it, and now I have muscle. The stronger your legs are, the stronger your knees are. Okay? And that's all around. You can't just be strong up top and not down here, like you're going to have to balance that strength. Okay? But you can see additional reinforcement for that joint. It mentions the ligaments that stabilize this knee joint. Let's see if we can figure out where these are. Fibular and tibial collateral ligaments. Fibular and tibial collateral ligaments. Okay? They're going to be... There's one on the fibula, which would be lateral. The tibia will be medial, and they're collateral. Okay, so they're on the sides of that joint. What about oblique and popliteal? Everyone knows back of your knee for popliteal, and that's great. It's an excellent reference point because you hear it a lot. And oblique tells you what? It kind of goes across. And it doesn't go specifically at a 90-degree angle, so it's telling you that. All that information helps you. And then the arcuate popliteal, again, most people know that it's popliteal, so it's the back of the knee, and that's just another aspect that we look at here. Okay, so where am I looking at here? You can see here, popliteal, you can see arcuate there. I can see collateral. Okay, these are all ligaments just reinforcing this joint. Right here, these are all tendons slash that we're going into the muscle that is going to be on top of that. So the ligaments are underneath it, and then the muscle will be on top. Anterior cruciate, posterior cruciate, I already told you how they're named. Anterior attaches to the anterior tibia, posterior to the posterior tibia, posterior portion of the tibia. You can look at that solid meniscus there, articular cartilage there, articular cartilage on the patella, because it's going to articulate with that joint there too. We got some solid ligament here, collateral. You have your cruciate ligaments there as well. Sometimes you hear people mention the MCL. It's random, but it's a thing. I have not seen it, but I've heard it mentioned in injuries before. So it might be one of those things that's randomly unique to each of us. I have heard it. I haven't seen it. Yes.
When I hurt my knee, my doctor told me that I strained my MCL.
Yeah. I'm not going to speak on what I don't know, but that's what I am going to tell you that I've heard that. Okay? So, this is a knee on a cadaver, so a dead person. All right? Knee joint injuries. The most common injuries to the knee joints are one of the 3 C's. They're the cartilage, the collateral ligaments, or the cruciate ligaments. Either way, none of them get blood flow. So, we're all into a bad story. Here we have a nice little hockey puck, and I'm grateful they labeled that for us. For those of us who are not athletes, okay, that may have looked at that and been like, what is that? But I don't know how many of you watch soccer or the fighting, the UFC fighting, when they do those kicks and they hit that. When you see that just dangle, okay, those ligaments, no, they aren't going to fix themselves. You have to go back in and fix each of those individually. That's a lot, and that's a lot of healing. And there's not just putting it together. They have to be sewn together because there's no blood flow to help nourish that tissue. So you have to go in and fix it holistically. And then, of course, the muscles and tendons that you move around that have to heal after that surgery. So it's pretty invasive. Look at here, the whole meniscus. This is horrible. That dude is out for a minute. Okay? Now we're moving on to the shoulder joint, the glenohumeral joint. It's freely movable. Up here, well, this guy's got plastic holding them, showing you the tendons and the muscles there, but it is movable. This is the joint that we looked at earlier. You can see articular cartilage, the synovial membrane, synovial fluid. You can also see the tendon sheath and the bursa there. All those are synovial membrane packets, like little bath balls or Tide Pods there. Okay, on a cadaver. What cut is this? Frontal cut, yeah. They just went. Okay, the coracohumeral ligament and then the glenohumeral ligaments. Coracohumeral or coracohumeral, that's what my students say. If you know where that aspect is, then humeral tells you that it articulates on or actually it inserts on the humerus. Okay, glenohumeral, that's within that joint. We're about to talk about our rotator cuff. Okay, I freaking hate when people say I tore my rotator cuff. And they have this idea, and it's just because they don't know. But I'm probably not the person, I'm just that person who stares at you. Okay, it's not a cup. There's not a plastic insert there that's there to reinforce your shoulder. The rotator cuff is a group of tendons that encircle this joint and support it. And could you tear that? For sure. Does it mean you tore all 4 of them or that whole group? No, it could be just one. And so then again, that's why they have to go in, they have to be, you reduce it, you don't move it, you allow the swelling to go down, and then you assess it. Where is subscapularis? Below the scapula, yeah, below. Okay? Supraspinatus or spinatus. Supra, what does that tell you? Above, okay, so just pull in as much terminology as you can. Infraspinatus. Infra would tell me it would probably be below, right? Interis, that's another term that we haven't learned yet. We'll come to that with muscle. Okay? But here you can see, again, we got some bursa. We've got a lot of ligament here. The acromion up there in my glenohumeral joint. The coracoid process. So the coracohumeral is going from there to the humerus. That was an anatomical thing, that's what I said. If you understood where that was, you could probably name that. But again, we have the cavity itself, the synovial cavity, then we reinforce it with ligaments. Here is the rotator cuff up close, what it looks like with just those tendons, and look at the shape of them. That shape reinforces the movement of that joint. On a cadaver, that looks like a chicken bone.
Yeah.
All right, elbow joint. Yeah, no, sometimes in my life, they say when you study anatomy, you should never compare it to food. I feel like I compare everything in anatomy to food. Like, that looks like a steak. That looks like corn. Okay, moving on. The elbow joint allows for flexion and extension only. It says that it is the humerus articulating with the ulna and radius at the trochlea and capitulum. Okay, nice looking elbow joint. You can see articular cartilage, synovial membrane, synovial fluid. I got some fat pads up there, some accessory structures. I have a bursa there. And you can see this is tendon. I know this is tendon because it's attached to muscle. If there's muscle, it's a tendon. If it's bone to bone, it's a ligament, non-negotiable. Okay, annular ligament, we'll get there because that kind of doesn't give you an idea of where it's at. I'll show it to you, but that doesn't tell you exactly where it's at. But what about the ulnar collateral ligament and radial collateral ligament? Ulnar collateral and radial collateral. Where do you think? Ulna and radius. And then they're collateral, so they're going to be on this side. So you can kind of see that here. Here's the annular ligament, and we're going to see a couple different views of it, and I'm grateful for that. Because this ligament is what allows for that radius to move, kind of move there. Okay, you have your radial collateral ligament there. Here you have ulnar collateral. You can see the annular there. Kind of just wrapping around the head of the radius. On a cadaver, hip joint. A lot of motion, a lot of muscle, so it just depends on the strength of that. It is ball and socket. It is where the femur articulates with the acetabulum, which is that groove area where the head of the femur fits. Hip joint, bone to bone. You can see articular cartilage, you can see synovial membrane filled with synovial fluid. I don't see much else here. I don't see a lot of bursa right now because I don't have a lot of ligaments or tendons there. I don't see any tendon sheaths. I do see basic ligaments for attachment, but that's about all I see there on that. Cadaver, again, that looks like chicken. All right, the reinforcing ligaments of this joint, your hip joint. I bet you can tell me where these are. Iliofemoral. Where's the ilium? Right. So iliofemoral is going to be from the ilium to the femur. Okay? Pubofemoral. From the pubis to the femur. Okay? Ischio. From the ischium to the femur, which is the butt bone. Okay, and then the ligamentarius, it just tells you it's ligaments there. So you can see that, the ilium, the ischium. Okay, pubofemoral there now too. So ligaments reinforcing that hip joint, and then we put a whole lot of muscle around it. Last joint, I believe, temporomandibular joint. Where is this? Right here, right. Where your mandible articulates with the temporal bone. There are two types of movement. There's a hinge movement that allows you to go, and then there's gliding movement, which allows you to go side to side. But ultimately, you don't want to move it a lot because sometimes it will dislocate itself. Like sometimes you're doing something or you're chewing gum and it locks, and that can be painful. Okay, it is a very easily dislocated joint, though. A lot of people do it often. So you can see that it's reinforced there by a couple ligaments, but it's pretty loose. Okay, articular cartilage, minimal synovial activity, but it is there. A lot of people get a lot of wear on this, especially if you chew gum a lot. this joint, oftentimes that cartilage begins to wear down. You start to get headaches. Showing you the gliding motion of that. Cartilage tears, what do you do when you have a cartilage tear? Well, it really depends on who the patient is, why it happened, and how old they are. Because if they're super old and they get a cartilage tear, the amount of stress that we're going to put them through in the healing process probably tells us we should probably negate the whole thing and just keep them comfortable. But if you have a 7-year-old or an 8-year-old, or you have a teenager who tears their cartilage, do you just let them sit? No, you look at it and say, hey, what can we do to fix this? And what are your goals as far as movement is concerned? You have to go in, though, and clean it out. You have to get all the scar tissue out, because immediately it's going to start to scar. That's your body's natural response. And then you have to fix the cartilage itself. Okay, so that's what it's referencing there. My favorite part of this picture is the reflective nature. Picture after picture, if you can see brightness, that tells you that's where that connective tissue is, that's where the damage is, right there. And that, of course, that's a meniscus tear. What is a sprain? A sprain is just a stretched ligament. That's all a sprain is. Sprains can range from being very mild to extremely severe. It just depends on how far that ligament has stretched. How do you handle a sprain? You elevate it and ice it. You rest it, elevate it, and ice it. Okay? If you tear that ligament and it's torn or it pops for whatever reason, you have to go in and sew it back together. It will not heal. If it's just stretched, it will heal with time. If it is torn, it will not heal. You have to replace it, either sew it together or replace it with other ligament grafts, so you take ligament from the other parts of your body, and it takes a long time for those to heal. Ligament damage is bad. So any damage is bad, but ligament damage is bad. Dislocations, you have luxations, which is a full dislocation, and subluxations, which are partial dislocations. A full luxation means it's completely out of socket, like that joint is completely out of socket. We see this happening in synovial joints because they're freely movable, like you do something like something pulls, and it just pulls it out of socket. When it's out of socket, it is not damaged itself. The tissue will swell up because it will become inflamed, but the ligaments have just stretched. Like you haven't broken anything, if that makes any sense. And a lot of times when it's out of socket, it just dangles there. Like, you can still move the muscle, but the bone's not there. So you can flex the muscle, but because the bone's not there as a leverage point, it just kind of dangles. Anytime you dislocate it, the only way that it's going to heal is if you reduce it. You put it back where it's supposed to be. And that's usually the most painful process. Again, depending on where that location is and the pain tolerance of your patient, you may have to sedate them. It just depends. Partial dislocations are where it kind of comes out of socket, but it sticks. We call that a subluxation. And again, you need to reduce it, bring it back in to its natural position. That's it. That's all you do with luxations. Bursitis is an inflammation of the bursa. So that's usually a joint that you use a lot. We see a lot of this happening with people who you hear tendinitis and bursitis, and that's usually in their forearm and their wrists. And what are they doing all day? Typing. They're at computers, yeah. So we see that a lot. They're wearing wrist braces, and they're icing it, and taking some type of NSAID for pain, like an anti-inflammatory. So it will leave ibuprofen, something like that. So arthritis is a symptom. There are so many different types of arthritis. We talked about this type of thing on osteoporosis the other day. Arthritis just means that your joints hurt. If you have acute arthritis, like it all of a sudden starts hurting, it's probably because there's an infection. If you are normally healthy and all of a sudden your joints are hurting, you probably have a bacterial infection. It possibly could be viral, but we take you to the doctor. If it's viral, it'll run its course, but if it's bacterial, we'll put you on antibiotic, and you'll be fine in a couple days. If it is a chronic arthritis, you probably have some type of condition that you've had for a while, and chronic tells us what? It's over a long span of time, and I shouldn't have assumed that you knew that. I apologize. Acute means it's a sudden onset. Chronic means it's been happening for a while. Like you say, I have this chronic pain in my back. It's been hurting for months. I have this sharp pain. It's acute. It all of a sudden occurred. Okay? That's how that might come across. Chronic forms, again, it mentions here osteoarthritis, rheumatoid arthritis. That's an autoimmune disease. Like, you can't get rid of that. Okay, gouty arthritis, uric acid buildup. Osteoarthritis, is it common that our joints are going to wear down? Yes, it is common. I'm going to tell you, and I've said this over and over again, and this is going to be like a thing, like a mantra. You take a shower, you do some type of exercise, you take a multivitamin, you eat right and take care of yourself, a lot of these problems will just kind of skirt past you. You take care of yourself, it's worth it. If you drink Cokes every single day, you're going to feel that earlier on in life. It's just the way it is. And those are just small choices that you can make. But it is natural for your joints to hurt as you get older. It is. You can forego that. Do some type of activity, strengthen those muscles, and they won't hurt as much, or if at all. It is common that in areas like, for example, if you do the same motion over and over again, like factory assembly line people, we see them, those cartilages wear down, and then it's bone on bone, and it becomes painful, and they can't work, and their job caused that pain, so now they can collect money from that company because of that. If you do have joint or muscle pain, you use like Icy Hot. It's talking about capsaicin creams, where it kind of, it's icy to dull the pain and hot to relax it, or whatever that commercial is. But you use those creams to help relax those muscles so that it doesn't hurt so much. Chronic arthritis, and as opposed, right here it's talking about rheumatoid arthritis. Rheumatoid arthritis, most people recognize it when they see people with hands like this. Rheumatoid arthritis is an autoimmune disease where your body attacks itself. So you can't cure it. And it continues to get progressively worse. Ultimately, it causes a lot of inflammation at your joints. It mostly happens to women. Of course, it can happen to men as well. You normally start to see swelling in joints a little earlier on in life, and it becomes painful, and then you go to the doctor, and once they diagnose you with rheumatoid arthritis, then it's pretty much just trying to keep you comfortable the rest of the time. Oops. No, I was right. Okay. You can use anti-inflammatories. You can get injections for that to try to reduce that. You could replace that joint, like take the joint out altogether, like have a knee replacement, a hip replacement, or something like that. That's also very common, but again, you don't do that on a very old patient because the recovery time is too much. But if you have a patient that's in their 50s and they're suffering and they are all the way together pretty healthy, they'll probably last another 30 years. You might as well let them get, put them on that list to get a hip replacement. But that's patient-by-patient analysis, and you learn your patients. Okay, gouty arthritis is caused by uric acid. Normally, what you see in gouty arthritis is, I call it a lankle. It's like their leg, calf, and ankle are all one size. And then it just starts to continue to swell. It's painful. They limp a lot. Sometimes they walk with canes. I can't think of terms sometimes. You can treat this with drugs, but a lot of times a lot of water will help work that out over time. You see this in people who drink a lot of alcohol, a lot of Cokes over time. So, have a healthy life. Lyme disease, you got bit by a tick. That's pretty acute. Like you didn't plan for that. You got bit by a tick and it gave you a little bacterial infection and it caused some arthritis for you. You take antibiotics 6 to 12 months to handle that. So just be careful when you're in the mountains. Developmental aspects of joints. I talked about earlier, last time we were together, that your bones start forming when you're around 8 weeks old inside your mom. Those joints have to start that early as well. Making sure that as you are young, you take care of your joints, that you're healthy, and you build your muscle to reinforce those joints. Over years, your body's going to take its toll, but exercise is key to keeping your joints nice and healthy and keeping you happy and out of the hospital. That's it on Chapter 8.